can all stay healthy, and no one suffers from hunger. We will only realize this vision together. Together, we will come back stronger. Together, for a future with health for all, hunger for none.
My journey continues, and I know I'm not alone. Because together, we can make a difference every day.
Many societies of echocardiography and cardiac imaging in Asian nations and the American Society of Echocardiography. He earnestly helped developing countries to enhance their capacity of echocardiography practice to become more in line with the standards set by the American Society of Echocardiography. I would like to introduce Professor James Kirkpatrick to chair the session and to introduce the session.
Thank you so much, Dr. Huai. It is a true honor and pleasure to be able to participate in this wonderful session. And I just want to say on behalf of the American Society of Echocardiography, what an honor it is to work with dedicated professionals from all over the world. It is our honor and privilege to do this. And as much as we believe that it is in our best interest to participate in international collaborations for the good of patients, I will tell you that one of the main things that we gain out of this is understanding echocardiography and cardiac imaging ourselves in a better way, because it is these international collaborations from which we all learn together. So today we have a very wonderful opportunity to learn from some sonographers. They are people who spend all of their days essentially doing cardiac scanning using cardiac ultrasound. These are highly dedicated individuals, and we have chosen some of the best people to present to you today. But I want to emphasize again that at the end of this presentation, we should have an exchange, a discussion that we are able to learn together and from each other as we go forward, because we all have something to contribute to advancing patient care and cardiac imaging. It's my pleasure to first introduce Mr. Keith Collins. He is at Northwestern University in Chicago, in Illinois, the state of the United States. Keith has been a long-time expert at imaging, particularly with three-dimensional echocardiography. And he is a trainer of trainers. That means that he teaches other people all the time and is a teacher of teachers. And so we're very honored to have him present on the tips and tricks of assessing mitral regurgitation by both two-dimensional and three-dimensional echocardiography.
Hi, my name is Keith Collins, and I'm lead cardiac sonographer and educator at Northwestern Medicine in Chicago, Illinois. I'm also chair of the ASCI Sonographer Council, and I'm going to be talking to you about assessing MR tranthoracically and giving you some tips and tricks. So it's important to follow the guidelines, and two of the most relevant are the guideline for evaluating native valve regurgitation, and that was led by Dr. Zogby and published in 2017. Dr. Mitchell led the group in 2019 on guidelines for performing a comprehensive transthoracic echo. Both are really great papers with a lot of good images and algorithms to evaluate regurgitation well. Now, what's in it for me as a sonographer, as an imager? In addition to multimodality approach, there's an emphasis on identifying the mechanism and etiology of the MR. In addition to using 2D echo, they advise 3D echocardiography transthoracically for further detail of those valve leaflets. There's an algorithm to assess the severity and, whenever possible, quantify. Now, a reminder of the mechanisms. It's based on Carpentier classification of MR and on leaflet motion. Type 1 has normal leaflet motion and can be due to endocarditis in addition to other pathologies. Type 2, there's excessive leaflet motion due to prolapse, flail, trauma. Type 3A would be restricted leaflet motion in systole and diastole, in rheumatic heart disease, radiation. In type 3, the restriction is only in systole, and it tends to be with dilated cardiomyopathy and ischemic heart disease. Now, the algorithm which I just spoke is here, and it's meaty. It looks very intimidating, but know that it's a combination of semi-quantitative and quantitative measures. Semi-quantitative measures like the density of and duration of the jet and some of the pulmonary vein flows. More quantitative measures are vena contracta, EROA, or effective regurgitant orifice area, regurgitant volume and fraction. And they give guidelines to estimate between mild, moderate, and severe MR. We're going to walk through a case or two and apply these. Now, this is my little cheat sheet of how I look at a valve. I look at the valve first, both with 2D and 3D, to understand the anatomy of the leaflet structure. I also looked at the left ventricle and left atrium size to see if the MR is contributing to dilatation. Once I look at the valve, I color the valve, and then I CW and PW Doppler. And that will give me more quantitative measures as we spoke, to assess or estimate. Now, I'm going to do a little briefing on probe placement, but again, Dr. Mitchell's guidelines is much more comprehensive. And a little bit on 3D of the mitral valve. Here we're using Philips, so some of the terminology, 3D zoom, are also relevant in others. The principles are the same, whether you use 3D zoom, 4D zoom, or do a different platform. Great. And so now that we have that information, let's look at one of our cases. On parasternal lung, we see an effusion, but we also see a low-functioning heart, an unhappy heart. And the leaflet, mitral valve leaflets are thickened and apically tethered, presumably due to the LV dilatation and global hypokinesis that we can verify in the apical 4. Now, restricted motion in systole, if you recall, due to ischemic heart disease would be type 3B. And when we first look at the valve, we color the valve in the parasternal lung, and that's the best place to measure vena contracta. And what we're looking for is the entire MR jet with the head, the neck, and the body as it extends into the left atrium. Sometimes you have to angle to get the whole structure or whole flow. And then we're looking for the narrowest neck at peak MR, the right part of the cardiac cycle. So there's mild central, an example of severe central, and severe eccentric, which is more challenging and less reliable. Now, some tips, again, angle to see the complete flow across the valve. You want to use multiple cycles because there will be respiratory variation as long as and ectopy. And we're looking for that narrowest neck. And again, parasternal lung axis is preferable, although you can measure in other views. Now in our lab, we do 3D volumes as often as we can. And what gives us a reliable 3D EF and volumes for the heart and a reliable stroke volume. Also, we can take a look and assess for regional wall motion abnormalities as a cause for mitral regurgitation. In this patient, we also did a 3D zoom with a high frame rate over 4 beats. So we can look from the left ventricular view and the left atrial view to see that apical tethering and the thickened leaflets. We applied color over the valve area, and we can see the coaptation and the source of the regurgitant jet. Now, another tool is PISA for EROA, regurgitant fraction and volume. PISA, proximal isovelocity surface area, is in this cartoon you can see with the vena contracta here. When you shift the baseline in alias of velocity between 30 and 40 for MR, you'll see shells of different velocities. And where it aliases, where the yellow meets the blue, is a measurement we want to take this radius. And that's applied in this formula along with peak MR jet. We can see we have a holosystolic jet. So the peak MR and this radius are what we'd be using to calculate EROA. And show us some of the challenges. We take it from multiple views, from the 4-chamber, the 3-chamber, the 2-chamber if it's actually a single jet. But you will see with these thickened leaflets, sometimes they can block the view of the actual coaptation. You may actually want to, instead of side by side, you may want to hide or suppress color to get that exact measurement. Now, just tips. ALA seeing velocity between 30 and 40 shifted in the direction of flow. You zoom in for reliable measurements. You reduce the measurement area, and it's tough, so you take multiple attempts. You measure from the leaflet tips to the ALA shell. However, PISA is built on many assumptions, including a hemispheric geometry of that shell. And we know the mitral valve in its native form is saddle-shaped. So EROA may underestimate in cases of secondary MR, and that's what we have here. It's also less accurate when there's eccentric MR and limited if it's non-holosystolic. Now, the semi-quantitative measures, we saw a dense holosystolic jet. When we pulsed the pulmonary veins, we saw systolic blunting. And so let's put it together. We see that we have a central jet, but it's less than 50% of left atrial area, so we're more in this moderate range. The quantitative measures, we see vena contracted 0.6, and its upper end of moderate. However, EROA and the regurgitant volume fraction are in the mild. And remember, it can underestimate in cases of secondary MR. One other thing is I didn't show you that there's mild AR and severe TR. It can also be confounded by ectopy. But overall, it gives us an estimate. So we would call this mild to moderate ischemic MR. Now, in our second case, we see a different situation. We see excessive leaflet of that posterior mitral valve leaflet as it prolapses into the left atrium, causing very eccentric, anteriorly directed MR. You can see that it would be difficult to measure the vena contracta in this view. And so we alias for PISA 30 to 40, and we take multiple views and attempts to align the jet. Now, you can see it's highly eccentric. We can also get a hint that there might be some structural problems here. So we take a 3D volume, and it's a little tough to see, but we do multiple 3D acquisitions to evaluate those leaflet scallops. And we do measure PISA, and we know it's not as reliable for eccentric jets, but we do want some quantitative measures to put it all together to estimate the severity. When you do a 3D zoom, we can crop it into multi-planes, and we can see the flail P2 portion of that mitral valve on transthoracic. So flail P2 automatically kicks it into the severe category of Carpentier type 2. Now, take-home tips, follow the guidelines. They're there for a reason. They help guide you in estimating MR. There's an emphasis on knowing the mechanism and etiology. As an imager, seek that out first. And then using 3D consistently will make it easier in those tough cases where you really need the data. There's an algorithm to assess severity, and whenever possible, quantify. I want to thank you for your attention and really appreciate the opportunity.
Thank you so much, Keith. That was fabulous. I think everyone can see why Keith was chosen as the sonographer co-chair for the 2021 American Society of Echo scientific sessions. I think he may be called upon for many other things as an educator because he is among the best that we have. Well, let's turn now to our second speaker. It is also my pleasure to introduce Ashley Davis. She is from Duke University in North Carolina, the state in the United States, and she is going to talk to us about aortic stenosis. So while we put up Ashley's video here, here we go.
Hello, and thank you for having me. My name is Ashley Davis, and I will be reviewing aortic stenosis, a thorough workup with echocardiography. Here's an example of an aortic stenosis protocol. These are also images in our regular protocol with additional images specific for aortic stenosis. Some of the additional images that aren't included in our regular protocol are a zoom on the aortic valve and peristernal long axis, measuring the LVOT and peristernal long axis, zooming on the aortic valve in peristernal short axis, using 2D in color and apical 5-chamber to line up a continuous wave, A pulse wave just past leaflet tips with an aortic valve closure click, continuous wave in the apical 3 chamber, using your PDOF probe to obtain a continuous wave Doppler in at least 3 views, maybe apex, suprasternal notch, and right parasternal, and reporting valve area on your final report. One additional thing we do is called the AS buddy, which means that you get a partner who will try to meet or beat your gradient and make sure that we have the highest gradient for that patient. It's important in aortic stenosis to use all available transducer positions. These are all options. Think outside of your regular scanning planes and try to get the best angle for that patient, which may not be your traditional transducer position. So we're going to start in the parasternal long axis. Your notch is pointing towards the patient's right shoulder, and preferably the patient would be in the left lateral decubitus position. Here's our parasternal long axis. We'll turn on color on the aortic valve in the parasternal long axis. We then zoom on the aortic valve and parasternal long axis, trying to display the leaflets and how well they're opening. We'll then freeze here and obtain the LVOT measurement in 2D, and this will be used for your aortic valve area calculation. So you want to make sure that you're in mid-systole with your valve leaflets open fully, and you're getting the full left ventricular outflow tract measurement. Now the sonographer is rotating from the parasternal long axis to the parasternal short axis. So your notch is starting at the patient's right shoulder, rotating towards the patient's left shoulder. As you can see, she drops down slightly on a lower rib space and then angles more anterior to get the aortic valve. And here's an example of the parasternal short axis of the aortic valve in zoom and with color. Now we're going to move to the apical window. So in the apical 4 chamber, you'll start at the apical 4 chamber and then angle anterior to get the apical 5 chamber or aortic outflow tract. So you can see she starts in a flat plane and then angles anterior to get that aortic valve. So you start with your apical 4 chamber, angle anterior, and get your best view of your aortic valve in the apical 5 chamber. Then turn color on, and you'll use your 2D image and your color image to help guide where you place your Doppler to obtain the highest continuous wave Doppler gradient going through the valve opening. So we're going to obtain a continuous wave with the imaging probe of the aortic valve gradient. Another example of a continuous wave in the 5-chamber aortic valve gradient. And we'll measure at this point if this is our highest gradient. Next, we'll obtain the LVOT pulse wave Doppler using the imaging probe again. So this is where you'll place your sample gate just outside of the leaflets and make sure that you see an aortic valve closure click to ensure that you're close enough to the valve. You want this sample gate to be placed in exactly the same position that you measured your 2D LVOT diameter. And you'll measure your LVOT pulse wave measurement. Next, we're going to move to the suprasternal notch. So if you're obtaining the forward flow gradient from the ascending aorta, you'll angle towards the patient's right. If you're getting your descending aorta, you'll angle towards the patient's left in a normally related arch. And here's an example of the suprasternal notch in the imaging probe. And turn color on. So now we're assessing the descending aorta, and a continuous wave Doppler through the descending aorta and the suprasternal notch with the imaging probe. You can also use PDOF in the suprasternal notch. So again, if you're getting your aortic valve Doppler, you're going to angle towards the patient's right and through the aortic valve, so the flow should be coming towards you. Next, we're going to move to the right parasternal window with the imaging probe. So the patient is now in the right lateral decubitus position, and the right parasternal window is typically just across the sternum from your traditional left parasternal window, possibly slightly higher by 1 rib space. So we can first obtain the image with the imaging probe, so we can find the aortic valve, orient ourselves, and get a good idea of what the angle will be. So we're looking at the aortic valve from the right parasternal right now with the imaging probe. We'll then turn color on to get a good idea of what direction the flow is going and find the highest velocities. And then we'll use continuous wave again with the imaging probe, lining up using our 2D and color images. Next, we'll move to the right parasternal with PDOF. So you'll be in the same location you were just with your imaging probe, but your PDOF will have a smaller footprint, and you'll use small angulations to listen and look for the highest velocity that you can find with your PDOF probe. And here's an example of that continuous wave Doppler obtained from the right parasternal window with PDOF. Another location to use PDOF is the supraclavicular location. So you're going to be on the patient's right, just above the clavicle, and you'll press down into the space at the crux of the clavicle and the neck, and push down, angle towards the patient's left. Be sure to avoid cross-contamination with the carotid arteries or superior vena cava, and find the aortic valve velocities. Here's an example. This one is a little faint, but an example of a right supraclavicular Doppler obtained by PDOF. Lastly, we don't want to forget our abdominal aorta. So you're going to start in your subcostal forechamber with your notch facing the patient's left. And as the sonographer rotates with the notch up to about 12 o'clock or facing the patient's chin to find the aorta, and then you'll angle slightly to the patient's left. So she's rotating from the notch being about 3 o'clock to closer to 12 o'clock and angling towards the patient's left to get the abdominal aorta. So reporting is important. So this is our final step in creating a thorough aortic valve stenosis assessment. So you want to make sure your report includes the peak velocity obtained from the highest place. So wait to measure your peak velocities and gradients until after you've obtained all of your windows to make sure you find the highest velocity. So we report peak velocity, mean gradient, the VTI of V1, the VTI of V2, the LVOT diameter obtained from 2D, the calculated aortic valve area, and also consider reporting the location of the highest velocity. So if you got that from the right parasternal or the apex, etc., that will help the next person performing this patient's exam to find the same gradient that you found. And that's all I have. Thank you to Dana Rivera and Brenda Sedberry for letting me borrow their heart and their hand to create these videos. And feel free to reach out to me with any questions. And I hope you have a great conference. Thank you.
Many thanks to Ashley for a phenomenal presentation. Extremely practical, extremely thorough. It's now my pleasure to introduce Eric Cruz. He is from the University of Chicago, which is no surprise, in Chicago, Illinois, in the United States. He is actually south of where Keith Collins is at Northwestern University. And it's a good thing that they're good friends, but only sometimes rivals. They actually were both at the University of Chicago for many years, and I had the pleasure of doing some training there as well. Eric is taking on one of the more difficult talks in this entire series, because we all know that the right ventricle is a highly complex chamber, and for him to be able to teach us about assessing the right ventricle is something that I am very, very happy that he is taking on, that I don't have to. Eric, thank you so much.
Well, thank you. Thank you for the invitation. It's quite a pleasure, and I hope that we get to get the overall experience with the right ventricle. I think that we've come a long way. So with that being said, I will now go ahead and share my screen. And just to give everybody a little bit of perception here, that's me on the left-hand side of the screen, and I'll be walking through some of the probe manipulation. And at the same time, you'll see some of the imaging on the right hand of the screen that will correspond to the images that I'll be getting. So I'll stop there, and I'll go ahead and play the presentation.
Hello, my name is Eric Cruz, and I'm from the University of Chicago Medical Center. I'm here to explain RV assessment using 2D and 3D. Just for simplicity's sake, some of the terms that I'll be using in referencing the maneuvers consistent with the guidelines will be the following. We want to start with our first and long axis. Obviously, the indicator will be towards the right shoulder of the patient. We want to start to the left of the sternum. So our typical view here, and you'll start to see the side-by-side image will be actual live demonstration, live scanning associated with the video. And so some of the terms we want to use is going to be tilt. So simply going to keep the head of the transducer on the patient, and we'll put the tail of the transducer toward the patient's left shoulder so we can see the RV inflow view. We're going to take the tail back and put it towards the patient's right hip. And there's our RVOT view, our PA. So we'll come back to home page. Will be our personal long axis again. And so the other term that I'll explain is just going to be simply rotation. So you're going to take the indicator, and we're just going to go clockwise or counterclockwise. Clockwise or counterclockwise. So that's going to be another term that we're going to use. And then lastly, we're just going to talk about rocking the transducer, which is simply going to keep the head of the transducer on the patient, and you'll go up and down. And obviously, that's to get the region of interest into the center of the screen. So we'll start off our typical person, a long axis of the patient. We want to assess the right ventricle. The typical patient, we're looking at the right ventricle here. It really kind of gives us a rough estimate of what's going on with the patient. Obviously, have our right ventricle up on the top of the screen. We can get a good sense based upon the ratio of the RV to LV in this view here. And simply, we can see that the RV is normal size. It is a poor assessment in terms of systolic function for this view, because it's geographically it's a little bit challenging. So what I'm going to do is just kind of show some of the maneuvers to look at the RV a little bit better. So what we want to do is go into RV inflow view. Is it going to tilt the transducer so that we're in the middle, keeping our tricuspid valve open. We're going to utilize our color Doppler. We can see nicely here that there's a little bit of tricuspid regurgitation. And the next thing that I'll do is just throw our continuous wave through the depth. Now, there's not too much of tricuspid regurgitation, but if we look at one of the spectral Dopplers, we'll see that there's some of the tricuspid regurgitation here. So simply put, when we measure this, we'll realize that this is the TR velocity, so 2 times the velocity squared, and we want to remember the right atrial pressure. So in this particular instance, we're at 14 millimeters of mercury without the inclusion of the right atrial pressure. Now what I want to do is I'll come back to our peristernal long axis, and I'm going to clockwise rotate the transducer. So the indicator now will be 90 degrees rotation to look at the RV at the short axis. The LV, you can see nicely the left ventricle in the middle of the screen, the right ventricle on top. And this kind of gives us a good estimate in patients with significant pulmonary hypertension. We can assess for volume and pressure overload based upon the septum, the shape of the left ventricle, and what is happening with the interventricular septum. Now I'll move on to our apical position. And what I'm going to do is I'm going to utilize the dropout that we have. Use a little bit more gel. So simply starting from the peristernal long axis, we're now putting the indicator down towards the floor or down towards the bottom. And I'll hold it as so. Go right to the apical part right here. We can just try to find our image. So there's 2 different images that we can get. Going to adjust my sector. This seems to be a nicer windows for this patient. What I've done there is I utilized the penetration of the settings here and took this to each time. All right, so this is our typical 4-chamber view of the patient. Indicator again is down towards the ground. This is our typical 4-chamber. What I want to do, just for the sake of focusing for the right ventricle, is kind of show that RV focus here that we talked about and why it's so important. So what I'll do is I'm just going to take the probe and I'm just going to slide laterally. So I want to slide the transducer a little bit more lateral and focus in on the right ventricle. And now we can cleanly see the right ventricular free wall of the patient. It's demonstrated here. And this is our optimal view for the right ventricular dimensions and the assessment of the patient, as well as the 3D acquisition. So I'm going to go back to our home base, which you can see nicely here. It's our 4-chamber. I'm going to slide down a little bit more laterally into the bed. You see that RV come in. Now I'm going to want to rock the transducer a little bit more, and perhaps give it a little bit more anterior tilt to get that RV free wall in. And so other tips and tricks is you'll start to see the aorta come in. That's going to be a poor assessment for the right ventricular dimensions. Then also sometimes you do too posterior of a tilt, and then closes off the right ventricle as well as the right atrium. I'll come back to the optimal view. And then another thing that you can get caught up in doing is that you can actually rotate a little bit too much. So I'm just, for simplicity's sake, I'm just going to counterclockwise rotate a little bit. And you can see that right ventricle start to shrink up a little bit more. You can see that the right ventricle is starting to close up. And so this would be an accurate assessment of the right ventricle because you're actually decreasing the size of the right ventricle. Let's come back clockwise. And this is a very nice assessment of the right ventricle here. So I'm just going to wait 2 cardiac cycles and then freeze. So for our measurements or our assessment of the right ventricle, we're going to measure a couple different things. What I want to do is look at the tricuspid valve to make sure that the valve is actually closed. And then we take 2 measurements here. So you'll have a basal measurement and you'll have a mid measurement, is what we like to utilize. And so you can take this cursor on down, draw it across. Now we can take another measurement just a little bit higher, so at the bit of the ventricle. And go across as well here. So those are just 2 quick and easy linear measurements that we utilize. The other thing that we want to do is do a TAPSI. So we'll just actually utilize pen mode. And our TAPSI. Measure the bottom. The other one is we can do an ASCI. I'll look at the end, it's right here. Or the TD, full stop letter. We're going to look into the P here. Okay, and then the next thing we're going to do is just look at the 3D. We want to go to full volume. This view here, what I like to do is look and make sure that we can get a little bit of glimpse of the right ventricular free wall, which is this part right here. So I'm going to change my beat acquisition to 4. Now I have the patient hold their breath, so hold your breath, hold your breath, hold your breath. Good. There is our 3D acquisition here.
Thank you. And I'm going to now try to get the PowerPoint to show up a little bit more here because I wanted to explain something a little bit further. So let me go ahead and share that again. One of the things that we want to focus in, particularly as it pertains to the right ventricle, is going to be the RV free wall, which I mentioned earlier. So when you're acquiring a 3D data set, it's extremely important to realize that this is going to be in multiple planes. And so the first image will be your traditional RV focus view, which is on the left here. And we can see nicely that RV free wall all the way up into the apex, encompassing the septum as well. And then we look to the right. And so this is kind of that pseudo two chamber. So this is another view of the right ventricle, but there's not too much assessment. Well, it's important to understand why we incorporate this. And so as Keith would mention here as well, is it's really important to realize something called stitched artifacts. We won't get into too much of that, but just realize that when you're using a multiple beat acquisition is that you want to make sure that there isn't a glitch to the image and that you can visualize the endocardium in both the proper RV focus view, but then also you want to make sure that you get the RVOT as it pertains to the right ventricle, because this is a really extremely important section of the right ventricle that's traditionally, and I would say all the times, it's missed with two-dimensional imaging. And thank you for your time.
That was phenomenal, Eric. We really appreciate your very comprehensive look at the difficult heart chamber to image. And I really appreciate in particular your emphasis on 3D. I personally think that that's going to be the future of right ventricular imaging. Obviously, your lab has led the way in doing that, and we appreciate all of your contributions to that, to both the literature and to training and teaching. Well, it's my pleasure now to turn to another sonographer that we have on the program. That is Becky Schwegler. And Dylan Johnson and Michelle Fujioka and Huang Win, all of them from the University of Washington Medical Center here in Seattle in the United States. These are our fabulous sonographers, and they have been tasked with discussing pulmonary hypertension and how to image it. So I really appreciate them taking on this important topic as well.
Hello, my name is Becky Schwegler, and I'm from the University of Washington Medical Center in Seattle, Washington. And on behalf of Dylan, Michelle, Hong, and myself, we would like to share with you some tips and tricks for obtaining the transpulmonic flow with notching and the tricuspid regurgitation jet in a patient with pulmonary hypertension. We wish you the very best for a successful ASCVI meeting 2021, and we hope you enjoy. Starting from the peristernal long axis view, we angle laterally to see the RV outflow tract. Peristernal long axis view, angling laterally to the RV outflow tract. and pulmonic valve. A good one. Going back to the parasternal long axis view, we are now going to rotate the transducer 90 degrees clockwise and angle laterally to see the pulmonic valve. Parasternal long axis view, rotating clockwise and angling laterally to see the pulmonic valve and RV outflow tract. Starting in the standard parasternal short axis view, we then pull down an inner space, allowing the head of the transducer to angle anterior and superiorly, so we see the RV outflow tract, pulmonic valve, main PA, and PA bifurcation. With this better image of the main pulmonary artery, we are able to line our Doppler flow parallel and place our sample volume just distal to the pulmonic valve. From the standard apical 4-chamber view, to better visualize the right heart, we're initially going to slide lateral and angle the transducer back medial. Again, starting from the standard apical view, sliding the transducer lateral and angling back medially to better visualize the right heart. From this view, it's common to run into rib artifact or lung artifact, so color Doppler and Doppler alignment is more difficult. Therefore, we will show you how to slide medially and over the right RV, RA, and the right ventricular apex. Starting from the apical 4-chamber view, sliding medially over the RV apex, and then sliding up an inner space to better visualize the right heart, allowing for better color flow Doppler, pulsed wave, and CW Doppler alignment. Starting from the standard apical 4-chamber view, again sliding medially over the RV apex and sliding up an inner space to better visualize the RA, tricuspid valve, and right ventricle, also a better color flow and Doppler alignment. If you are off axis of the long axis plane, and when the patient sniffs, the image will go out of view and you will not be able to identify if the IVC collapses with sniff. So with interference from the lungs, the liver, ribs, we don't see the beautiful long axis of the IVC, so that when the patient sniffs, we cannot see the true IVC. For subcostal images, it is important to make sure that you obtain a good long axis of the IVC so that upon sniff, it stays in the frame of the image, versus a beautiful long axis evaluation of the IVC. So when the patient, either with normal respirations or with a sniff, we can keep the IVC in plane and see that it does collapse upon sniff.
Wonderful. I have the privilege to work with these very talented sonographers every day. I can tell you they are amazing in what they're able to get with an ultrasound probe, and also in their education of the attendings and the fellows who work with them. Well, right now we're going to bring back Ashley Davis from Duke University in North Carolina, United States, and she is going to talk about pericardial disease.
Hello, my name is Ashley Davis, and I will be discussing pericardial disease and a thorough echocardiogram workup. This is an example of additional protocol steps for pericardial disease. Some things we include is turning on the respirometer for the entire exam, annotating inspiration and expiration on a subcostal image for communication, a subcostal long loop showing the diaphragm with the respirometer to show a respirometer waveform, a long loop of the 4-chamber with the respiratory cycle to assess for septal shift, pulse wave Doppler inflow with a slow sweep speed and the scale optimized for inflow, color inflow of the mitral valve with a color baseline raised to between 30 and 40 centimeters per second if you're assessing constriction and restriction, pulse wave and color of Doppler hepatic veins with the respirometer at a slow sweep speed. Additional valves for respiratory variation as applicable. Suprasternal notch pulse wave of the aorta with a slow sweep speed for respiratory variation. Consider a high left parasternal view of the ascending aorta looking for dissection. And consider the M mode of the RVOT and also color of the aorta looking for dissection. It's important to use all available transducer positions. The heart may be in a different position depending on the pathology present, and you may need to be creative about what positions you use to get good angles and good images. So we're going to start at the parasternal long axis view. We're going to start with increased depth to show pleural effusion versus pericardial effusion. Then we're going to take a regular depth parasternal long axis showing the pericardial effusion. We're then going to rotate from the parasternal long axis to the parasternal short axis. So starting with the notch towards the patient's right shoulder and rotating towards the left shoulder. We're going to start in the short axis view of the papillary muscles, assessing the size of the effusion and the effect on the left ventricular function. We'll then angle anteriorly to look at the RVOT to assess for RV collapse in diastole. You can also look for RA collapse and systole in this view. So from this view, from your papillary muscle short axis view, you're angling anterior towards the patient's chin in order to get this more basal view of the heart. You'll then take your cursor and put an M mode through the RVOT and the parasternal short axis. M mode is very good for timing, so this will help us assess the RVOT free wall to see if there is collapse during diastole of the RV free wall. Then moving to the apical forechamber, we're going to sweep anteriorly and inferiorly to look at the largest view of effusion and take a. Here's an example of an apical forechamber. You can see the effusion encircling the heart. You're looking at the right atrium for systolic collapse, the right ventricle for diastolic collapse, and looking to see if the effusion is affecting the left ventricle. We'll then put the cursor in the middle of the left ventricle and turn on the respirometer. This will help us assess for RV swing, or I'm sorry, heart swing, to see if the heart is moving in and out of the view of the cursor and giving us false readings for respiratory variation on our mitral inflow. We'll then turn on mitral valve inflow pulse wave at the leaflet tips. You'll then slow the sweep speed down, so the sweep speed is at 25 millimeters per second. Turn on the respirometer, and it's helpful if you position the respirometer just above the mitral valve inflow so that you can assess for respiratory flow variation at inspiration and expiration. You can measure inflow respiratory variation, so you're looking at a difference in 10% if you're using the peak velocities of the highest peak and the lowest peak, or if you use VTIs, you're looking for a 25% difference in the VTI at the highest peak versus the lowest peak. We're then going to move to the subcostal forechamber.
Very nice. Got a little bit of.
And we're looking again for the size of the effusion, the effect on the right ventricular wall, right atrial wall, and to see if the effusion goes all the way around the heart. We'll put another M mode through the right ventricular wall. This will just give us a different angle of that free wall of the right ventricle, again looking for diastolic collapse. And again, M mode is very good for temporal resolution, and that will help us assess the timing of the right ventricular collapse. You'll then rotate from your four-chamber, subcostal four-chamber to your IVC, so moving the notch from about 3 o'clock to around 12 o'clock, and angling towards the patient's right to get the IVC. You'll then want the patient to perform a sniff, and again have the respirometer on and display sniff for the person reading the exam to be able to know what you're doing. So you're looking for IVC collapse or a dilated IVC without collapse. We'll then move to the suprasternal notch. And in this suprasternal notch view, we're looking at the descending aorta. This is a good stable place that will not have heart swinging interference in your Doppler, so you can get true respiratory flow variation without having the patient's breathing or the swinging of the heart giving you false readings. So you're looking at the suprasternal notch, and then pulse wave of the descending aorta. And again, we'll slow down the sweep speed. This one again is at 25 millimeters per second. And respirometer is turned on. So you're looking for respiratory flow variation in the descending aorta, which would tell you there is true respiratory flow variation in that patient. Some additional considerations when you're assessing for pericardial constriction: looking for an increased thickness of the pericardium. This patient's posterior wall ends and the pericardium is very thick compared to what you would normally find. You're looking for a septal shift with respiration or with inspiration. So as this patient breathes in, they have additional flow coming into the right ventricle, which is because their heart can't expand, is pushing that septum over towards the left ventricle. So you're looking for that septal shift with inspiration. You want to perform a propagation velocity. So the sonographer is in the apical forechamber, turns on color, and places their color box over the mitral inflow. She's then going to raise the baseline, so raise the baseline up towards the top between 30 and 40 centimeters per second, which will give you a nice outline of the inflow. And then you'll freeze and scroll back, and you want it to be at a slow sweep speed so that you can measure that propagation velocity. So again, you're going to turn on color, place your cursor at the mitral valve inflow, right through that inflow as the valve opens. Raise your color baseline and look for the difference between the blue inflow and the red outline. So you're looking for a fast propagation velocity if you're looking for constriction. So it'll be very, very upright slope. Another thing that you should look for is septal versus lateral DTI. In a normal patient, the lateral DTIs should be larger and fat moving more and moving faster than the septum because it's a free wall. In constriction, your lateral wall may be stuck to the pericardium and not moving as freely. So in this patient, you can see the septal DTI is 9.47 centimeters per second, and the lateral is only 6.29. So that would be an abnormal finding, which would lead you to constriction. You also look for a hepatic vein pulse wave with the respirometer on, and you're looking for systolic reversal of the hepatic vein. Things to consider reporting are the presence of the effusion, appearance of a thickened pericardium or a stuck pericardium, respiratory flow variation in any valve, IVC collapse, collapse of the RA in systole or the RV in diastole, septal shift during respiration, increased propagation velocity, or I should say fast propagation velocity, abnormal septal to lateral DTI comparisons, hepatic vein reversal, and also consider what is causing the pericardial disease. So it may be malignancy, it may be a viral disease, it could be aortic dissection. So thinking through what is causing the disease can help you work up the rest of the heart. Thank you to Danny Rivera and Brenda Sudbury for letting me borrow your heart and hand. And please reach out to me if you have any questions. And thank you for inviting me. I hope you have a great rest of the conference.
And thank you to Ashley. What a great job of assessing a difficult topic in a very short period of time, but doing so very comprehensively. Well, now it's my pleasure to bring back one of our own University of Washington sonographers who had been featured in the prior video, and that is Dylan Johnson. And he is accompanied by Becky Schwegler, who is narrating the last video. And they are going to take on another difficult topic, and that is congenital heart disease, and giving some tips and tricks of basic scanning.
Hi everybody, my name is Dylan. I'm one of the cardiac sonographers here at UW Heart Institute. Sorry I wasn't able to join live, however I put together this short video to go over some basic tips and tricks for scanning patients with congenital heart disease. And then thank you, Becky, for helping me put some of this together. So here's some basic pathologies we'd like to cover. ASDs, VSDs, AV canal defects, PDAs, pulmonic stenosis or RVOT disease. I'll cover Epstein's anomaly case, and then towards the end I'll touch on some techniques that we use when scanning patients with complex congenital heart disease. We'll cover atrial septal defects, so we want to make sure we evaluate the septum with 2D and color. We want to sweep through and scan the entire septum anterior to posterior. Make sure our box is big enough to cover the entire septum and lower our Nyquist limit so that we can distinguish between caval flow and atrial septal flow. And if there's still a question, you can always do an agitated saline study to evaluate the size and the direction of the shunt. So this image is a peristernal short axis on a normal patient, just showing the color box over the entire septum and our Nyquist a little bit lower. What we can do from here is drop down an interspace and angle back anteriorly so that we can see a little bit more of the septum and catch it at a different angle. So this next image of a patient with a secundum ASD, the jet is coming directly towards us, which makes it easier to visualize. Next, we'll cover ventricular septal defects. We use a similar technique to evaluate the septum that we do for the atrial septum. So from multiple imaging planes, we'll sweep through the entire septum, have our large, tall color boxes cover the entire septum, so when we're sweeping through, we don't miss anything. We can start at this higher interspace, kind of evaluate for perimembranous defects, and then the same thing with the ASDs, we can drop down to a lower interspace, and that way we can visualize more of the muscular septum. So from this plane, sweeping left to right slowly with the color box over the muscular portion, we can be sure not to miss anything from this view. And this image here is showing a patient with a patch repair of their perimembranous VSD. We're slowly sweeping through to make sure there's no residual shunt in that area. If we work our way back to the base of the heart from a long axis, we can see a supercritical VSD that will show again from a short axis. And these short axis views I find extremely helpful for ruling out VSDs or visualizing VSDs really well. We start at the base of the heart and we slowly work our way down to the apex and slowly work our way back up. Again, keeping that color box really wide so we can cover the whole area. So here we do that here. Sorry, the image is backwards. But we start kind of high at the base of the heart and then angle inferiorly all the way to the apex. If we can't see the apex from this particular spot, we can always move a little bit lower. And here's just that supercristal from a short axis. And then showing a perimembranous from the short axis, we're just a little bit lower into the LVOT. And then here's another perimembranous VSD. And like I mentioned, we can move to a different plane. So at the apex of the heart, we'll cover the septum entirely, keeping that tall box. Like in a different example of a patient here, if we can ignore the other pathology, the sonographer in this picture was evaluating for tricuspid regurgitation. However, the box was tall enough so that we were able to visualize that apical VSD there at the top. And moving on to endocardial cushion defects, I want to talk about imaging of cleft mitral valves. It's not uncommon for us to see patients with unrepaired partial AV canal defects, which are associated with these cleft mitral valves. And it's very important to visualize that anterior leaflet well. So this image here is a patient with a clear cleft mitral valve. There's that discontinuation of the anterior leaflet, and we can see where their mitral regurgitation is originating from. It can be easy to mistake the mitral chordae for the anterior leaflet. Even in this view, we can drop down a tiny bit lower and make a false discontinuation of that anterior leaflet. What we need to do is just angle up slightly until we're in the LVOT and then just back down until we see that anterior leaflet well. Next, we'll talk about imaging for a patent ductus arteriosus. It's important to visualize the branch pulmonary arteries well, and so we'll utilize high and low peristernal short axis views, and then we can pop up to the suprasternal notch view and show the relationship of that PDA to the aorta. And again, just keeping those tall color boxes and interrogating those areas with pulse wave and continuous wave Doppler. This image here is just a basic peristernal short axis of a normal patient where we see that pulmonic valve, but we don't see the branches quite well. And so in that instance, what we can do is rotate just slightly clockwise, drop the tail, and angle anteriorly. That way we can get into the pulmonary arteries, like in this image here. And we'll add our color and make sure to cover that far field. And if there is a PDA, like in this patient next, just distal to their pulmonic valve replacement, you see that red flow coming towards us, and that's that PDA. And if the imaging will allow it, like the patients in the NICU that have really good imaging, we can pop up to a higher short axis and just point a little bit more posterior, and we can see the branch pulmonary arteries next to that large PDA. And then from there we can move to that suprasternal notch view. This one's a little bit modified. We rotate slightly clockwise, and we kind of get this modified view where we see the aortic arch, but also the branch pulmonary arteries, and we can see a clear communication between the aorta and that PDA shooting into the right pulmonary artery. And since we learned how to visualize the pulmonary arteries a little bit better, we can use those same techniques to help visualize any type of outflow tract disease or distal disease that the patient may have. A lot of times we see this in our tetralogy of Fallot patients or patients that have had conduit repairs, but it's just very important to try and get as parallel to flow as we can, especially with the pulmonic stenosis. So we can take this example again. We know where their step-up's going to be, but we can use our pulse wave Doppler to, pulse in the RVOT, pulse in the pulmonic valve, and in the main PA and in the branches if our Nyquist limit allows it. And then from there, use our continuous wave Doppler to evaluate for the highest peak that we can get. I just wanted to bring up this patient here. They had a infundibular muscle bundle that was obstructing their outflow tract, and as you can see, I'm very parallel to flow. And so a movement that I made was actually going above instead of coming down. I moved above that region and get that jet coming towards me. We were able to prove that this outflow tract obstruction was severe. And so the key takeaway point there is just trying to get as parallel to flow as we possibly can. Next, we'll show a patient with Ebstein's anomaly, where they have that septal leaflet of the tricuspid valve displaced into the apex. And we learned a lot from the echo as far as the degree of that valve displacement, the competence of the tricuspid valve, and whether there's any right side enlargement due to that tricuspid regurgitation. The tricks here, in order to see that better, are similar to the tricks we use to see the right ventricle better. So in this kind of modified apical 4-chamber view, we slide the probe out laterally on the chest, and so we see more of that right ventricle instead of just being on top of the left ventricle. And then the opposite is true. Instead of moving out lateral, we can move medial, which in this view here, we pop up a couple interspaces, move the probe a little bit more towards the sternum, and then often point posterior. That way we still keep the right ventricle in view and we can see the valve a little bit better. And last couple things I wanted to discuss were some techniques that are more helpful in patients that have more complex congenital heart disease. We can do some sweeps from subcostal to show any form of heterotaxy as well as venous and arterial connections. Oftentimes, to help me determine systemic and pulmonic ventricles, I will follow the artery that leaves that ventricle and see if it bifurcates or turns into the arch. So we'll start with the subcostal sweep here. We begin posterior and angle anterior. So on the echo image, we have spine in the middle, IVC on the right, and aorta on the left. You can see aorta drop behind, and then IVC drop into the right atrium, so that we have the heart on the left side and then the liver on the right side, improving situs. And without getting too advanced, here's a way to see the ascending aorta a little bit better. We move up the chest and then have to point the probe a little bit back towards the hips. And so on the echo image here, you can see it change a little bit as we move from the base of the heart towards the ascending aorta. Well, thank you for having me, and I hope you found some of these tips helpful.
Absolutely. That was a phenomenal job by Dylan. He is one of our true star sonographers and is proving to be an excellent educator as well. Well, for our final talk of this session, we're going to bring in someone else who has been an excellent educator for many, many years. Carol Kraft has been scanning for a really long time, and she is an exceptional sonographer. We're so grateful and pleased to have her do the second of our congenital heart disease scanning tips and tricks talks. She is also from the University of Washington Medical Center here in Seattle, and it is a true pleasure to be able to work with her.
Hi, I'm Carol Kraft, and I work at the University of Washington Medical Center in Seattle. And I'm hoping that this is going to be a great session for you guys at the 2021 ASCD conference. Today I'm going to talk about different congenital heart defects, including ASDs, VSDs, and coarctation. I'll try and give you some tips and tricks on bringing different processes and blood flow out. So I'm going to get started with taking some images from peristernal. So this patient has had an aortic valve replacement, a VSD patch, a coarct repair, and an ASD repair. So today, as I started off in the third or fourth intercostal space, left sternal border, I realized I needed to slide a little lateral from their chest, from their sternum. So I slid out lateral in order to see the left ventricle better, as well as the aortic valve. The first thing I'm going to do here is turn on my color. I'm leaving my hand in the same position, and I turn on my color and to look for a potential perimembranous VSD or a patch lead. So as I turned on my color, I'm looking at my septum here, and I'm going to start scanning medially through the septum towards the tricuspid valve. Notice I'm using both hands to scan slowly medial through the patch over to the right heart and back. At this point, I did not see any VSD, so I'm going to rotate towards my short axis plane, rotating medial or clockwise, looking at the ventricular septal patch. I move down slightly. We have shadowing from the rib here, and this is the area of the patch. You can see it's brighter and the myocardium around it is thickening, but the patch isn't moving. Again, I'm going to turn on the color flow to help identify any areas of potential patch leak or any VSDs. I'm sweeping towards the patient's head or superiorly to look for any leaks along the patch. Currently my frame rate is pretty low, so to optimize frame rate, I can decrease my sector width of the color box, as well as decreasing the sector width of my 2D image to help optimize frame rates and to help bring out any flow velocities that I might be missing. At this point, I have not seen any VSD flow, and I've gone back to my long axis plane. You can also see here with this VSD patch in the long axis plane how we get shadowing behind the patch posteriorly as well as a little bit there, and that's just from typical patch material. If I want to rotate around to a short axis again and sweep up to my aortic valve and see the AVR in the center of the screen, I've moved down to a lower inner space to try and optimize the right atrium, and you can see here I'm in about the 5th or 6th intercostal space, mid-clavicular line, to try and optimize the intraatrial septum. The other thing I'm going to do, I'm going to change my gray map to help define the atrial septum a little bit better, and each manufacturer will have different gray maps. So when you're scanning anybody with congenital heart disease, it's okay to change maps and processings to try and optimize your image that you're looking for. So from this modified short axis plane, I'm going to turn on my color to look at the intraatrial septum. Notice here, the color scale is up pretty high at 67 centimeters per second. I'm going to decrease that color scale to, in this case, I decreased it to 38. And now I've increased it again back up to 46. So somewhere in the 30s to 40s to try and look at lower flow velocities along the atrial septum to look for any potential communication. Some other nice things that I like to do when I'm looking at the atrial septum is turn on a color compare so that the physicians can see the 2D image and the atrial septum with and without color at the same time. I'm going to move on now to the apical window. I'm going to feel for the patient's PMI. And I generally do this on all my patients in order to find the correct spot to put the transducer. I'm going to ask the patient to scoot down towards the foot of the bed a little bit. Perfect. So from this window, we see all 4 chambers, as we all know. And if I was doing a complete study on this patient, I would look at the left ventricle and left atrium. In this case, when I'm looking at the ventricular septum, I'm going to focus on the continuity of the septum here. And we start to get a sense that there might be a little bit of small separation in the distal ventricular septum. And when I put my color box up there, we start to see what looks like some VSD flow. And as every good cooperative patient does, this patient started having a few PVCs there, so it made it a little trickier picking out the regurgitant or the ventricular septal defect flow in this region, and we start to see that there, and you can see it's in early systole. And we see both systolic and diastolic flow with the color. At this point, I would bring up my cursor, and there might actually be 2 small little areas of communication, one above the other. And I put my mark of where I'm going to be focusing my sound beam with the continuous wave. I'm going to reposition. I didn't pick that up at that moment, but I'll just be patient and move my cursor to try and optimize the flow velocity. We're starting to pick this systolic flow up here. I'm probably not perfectly parallel to that flow. In addition, we're seeing some diastolic flow in this region, and I suspect that is low velocity because the pressure difference between these 2 chambers is low during diastole. And so that would be expected. Whenever you're doing a patient that has congenital heart disease, it's not uncommon to find VSDs anywhere along the ventricular septum. And in this case, this VSD is pretty distal towards the apex. So again, we're going to rotate the transducer to try and optimize the ventricular septum to bring out the communication between the right and left heart. My goal is always to become parallel to that flow velocity, so if I need to slide in medial to pick that up, I will do that. And again, I use the color to help guide me to try and optimize my flows. And it's a very small VSD, so it's becoming more tricky to pick it up. And here we've got it. Velocity is low. Again, that would suggest that either right heart pressures are high during systole or I'm not parallel to the flow. So I would continue to work on optimizing that flow velocity. We typically will look at the atrial septum from the apex, but it's difficult to tell if there's atrial septal flow. This patient's atrial septum was closed. They had a prior ASD. Again, if I increase my color, turn on color here, I can look for any possible communication. It's not the best window to do that from, so we'll look for the atrial septal flow from subcostal as well. Another good rule of thumb is with VSDs, if you're having trouble picking up the highest flow velocity, you might choose to use your PDOF transducer. I'm going to go ahead and move on to subcostal. So first thing I'm going to do is I'm going to get rid of a little bit of this gel, and then we'll have the patient lay on their back. We have some cushions we put behind patients in order to allow them to have support during the echo. Go ahead and rest your arm down by your side. You'll find having the patient rest their arm down that it helps allow their chest muscle and sternum to relax. And having the knees bent can be helpful as well. I'm going to take some images from subcostal window to get more perpendicular to your atrial septum. Take a big breath in for me and hold. And breathe. And again, a breath in and hold. So I zoomed up on the atrial septum to focus in on that. And here you can see we're nice and perpendicular. This atrial septal patch is not leaking at all. And we get a good look at both with and without the color. Go ahead and breathe. And if I don't tell you to breathe soon enough, you breathe whenever you need to. We can also try using color from subcostal at the ventricular septum. Take another breath in and hold. And breathe. So by moving the color box down into this ventricular septal apical region, we can try and optimize any flow across the ventricular septum. One last time, breath in and hold and breathe. I also know that this patient's had a coart. Oops, sorry, I keep trying to record. Take a breath in for me and hold. I'm going to angle over towards the patient's abdominal aorta. And you see that on the monitor here. Go ahead and breathe. And when you're ready, another breath in. Good, and hold. And breathe. We can look at the color flow and use pulse Doppler in the abdominal aorta. To help us figure out how significant a coarct might be. So one more breath in and hold. This is also, as you all know, a great place to evaluate for runoff if somebody has, go ahead and breathe, if somebody has aortic regurgitation. So here I decrease my wall filter to optimize flow during diastole to look for any significant forward flow or runoff during diastole. When somebody has a significant coarct, you might see a blunted systolic filling and then diastolic flow that lingers on and never flow that comes straight down to baseline. We'll do one more flow here. So another breath in and hold. And breathe. So here we see the forward flow, a little bit of early diastolic reversal, and just some forward flow there, and no long diastolic filling pattern. And last but not least, I'm going to take a look at the aorta from above. So conveniently, the patient's removed the pillows, and I'll put the transducer in the suprasternal notch. we're seeing ascending aorta, and then there's a sharp angle at the region of the arch itself. And when patients have had surgery, sometimes there's some scar tissue at the notch, so it can make it a little tricky to optimize that window. My color velocity scale is pretty low, so I'm going to increase that velocity scale again, just to decrease the amount of noise we're seeing. And as I change my angle, so again, looking at descending aortic flow, we increased our velocity scale. We can see here that the aorta is a little bit dilated in this region, and then if we look at the color part, we see a little acceleration of flow here, and on the medial curve there, not a lot of acceleration. So I think there's a little post-stenotic dilation with suggestion of a little curve in our color. To evaluate for the significance of the stenosis, we're going to start very high in proximal, and we will start with pulse Doppler proximal to where we think the stenosis is, and get a velocity. Here the velocity is about 0.75 meters per second, or 75 centimeters per second. And then we will move our sample volume into the area of acceleration. And there's a slight step up to 1.2 meters per second. And as we follow the flow velocity more distal with pulse Doppler, it steps up a little bit more, just above 1.2. And then to confirm that, I can switch into our guided CW, continuous wave. I decrease my overall gain and the velocity scale just to optimize our signal. And we're getting about 1.5 meters per second, or 150 centimeters per second. If I was concerned about it being more significant, again, using the PDOF transducer is something that can always optimize your Doppler signals. I hope this was helpful to everybody that was participating in the conference today, and best of luck in your future of scanning congenital patients. It's a fun thing to do. Thank you.
Many thanks to Carol for a great presentation, really walking us through. It's almost as if we're there in the room with her, helping us to actually get better at scanning. Well, we're moving into our discussion section here, and I'm very grateful to have Dr. Y able to help lead this discussion today.
Thank you very much, Professor Jane Kirkpatrick, and thank you for all wonderful speaker for the wonderful talks. Really elite and a wonderful party. We have many questions from the audience. Although we have just a few minutes left for the discussion, but I think I will read some question. I think Kate Collin, you can help with the question. In aortic stenosis, how can we put the Doppler sample volume exactly at the same position where the NVOT diameter was measured on parasternal long axis view?
Keith, I think you're muted still.
Unmute.
There we go. You had to let me unmute. they talk about one of the challenges. When there's big calcification, it's difficult to know exactly, and there's reverberation artifact, and it's difficult to go in the proper placement of the LVOT. Sometimes it's contaminated, and you have to struggle a little bit. Sometimes it's a little displaced more into the outflow tract, or to accommodate for that noise caused by the calcification.
Thank you so much, Kate Colleen. And I have a question for Eric Cruz. In imaging the RV, I find very difficult to, sometimes I find difficult to find the true apex of the RV. Do you have any tip in this? Thank you.
Yeah, so I think that's a great question. I think that's one of the most complicated regions of interest to get into the image. And I think it's really important, and I often speak to the sonographers about this. I think in a normal patient, it's actually a little bit more difficult than patients with a little bit more large of a right ventricle. But tips and tricks that you can do are really optimizing the patient positioning, having the patient on a steep left lateral position, and then also utilizing the breath hold. It's really optimal for patients. Some patients, it's a really big breath in. Some patients, it's a breath out. So I think it's just working with the patient to understand, which breathing techniques are optimal for the patient.
Thank you so much for your explanation. And one question for Kate Colleen. Can you advise on how to limit the stitching artifacts when we do 3D echo?
There we go. Yes, it's one of the, it comes with time. Unfortunately, you didn't hear me acquiring the 3D volume there. I noticed that in my patient, his best pictures were with the breath out. So I had him breathe in and then breathe out, and then he could hold it relaxed for 4 beats. And that's gonna, sometimes you get started with 1 beat when there's ectopy with a difficult patient that can't control his breathing. You can also use a HVR mode, high volume resolution. It's a single beat, but it's signal averages to do that. With time and practice and patient cooperation, you can avoid stitch artifacts.
Thank you, Kate. And there is one question. How about the role of strain imaging in constrictive pericarditis? Should we perform speckle tracking echocardiography routinely in this patient?
Is that for me or for I think Ashley was the constriction, but we routinely do speckle tracking and strain tracking in every patient possible. It's additive information. Whether you use it is up to the reader, but it's important to show the tracking that in each of the views so they know their confidence level in reporting the values.
Thank you. Thank you very much. And we have one question, I think, for Eric and Case, if you can have. What is the best view to visualize the persistent left SVC?
It's funny. I just had one today. It was fun. You don't see it that often, but when you do, it's you can. Eric, do you want to grab this or?
Yeah, I mean, you want to talk about your experience today, and then I can add to it.
Sure. And in the parasternal lung, you notice the large SVC, and when doing a bubble study, I could tilt posterior to have the dilated coronary sinus in view, and I'll see bubbles enter from that coronary sinus, but also from the parasternal, I will see them filling the SVC prior to filling the left atrium. So both are confirmatory views for persistent left SVC.
Thank you very much. Great experience. And a question regarding ASD. In case of ASD associated with atrial septum aneurysm, which additional views we should obtain and which additional parameters we should measure?
Yeah, I think it's a great question. I think in terms of ASD views, I think that one of the first things that we do at our institution is we want to really be able to utilize multiple imaging planes. I think that you can use your personal short access to be able to visualize that. I think it's becoming about sonographers to understand how the color flow is. Meaning if you have a personal short axis, you want to be able to rock the transducer a little bit more to visualize where that color flow is coming from. Certainly you can apply the same concept for an apical image, honing in. Sometimes what I like to do is just modify the image to just focus on just the interatrial septum and not to get the complete heart, meaning the ventricle, too much of the ventricle in plane, with utilizing the tilting and the rocking techniques that we mentioned earlier. And then lastly, certainly you can do the subcostal views, which we showed earlier, to really optimize your ASDs and PFO. Something of note too is that we utilize our scales. So we like to, traditionally it's about 40 or 50 to 60. We like to optimize it to around 40 to decrease the scales, the coloring scales, to be able to appreciate more of the color flow associated with it. So those are just some of the techniques that we do to help visualize it. Great.
Thank you so much, Eric. I think we have run enough time. I would like to invite Professor James Kirkpatrick to summarize the training session.
Thank you so much, Dr. Y. This has been a wonderful session. And I really appreciate all the insightful questions that you read off to us from the audience. We all have expertise that we can bring to this. But I think that we learned many things during this session. We learned some basic scanning and techniques and how we move our hands to get the optimal images. We also learned some very special things that maybe we don't use all the time, like the PDOF transducer. But we learned about how important the PDOF transducer can be, especially to get the maximal gradients and to fit into spaces that the other transducers have difficulty in getting those optimal velocities. We learned also about 3D, and I just wanted to emphasize in particular the use of 3D in mitral valve and in the right ventricle, as Keith and Eric illustrated so well for us. And finally, I think that we learned a bit about congenital scanning, at least on a basic level, and some of the tips and tricks that are going to be very important as we all move forward. And I personally want to thank all of the sonographers who participated tonight from all of our different institutions. I think they did a great job, and I learned a lot listening to this session. But the thing I really want to emphasize again is something we mentioned at the beginning, and that is that these international collaborations are very, very important for the future of all of us in learning things. We all learn together. We learn from questions, we learn from answers, we learn together. And to that end, I just want to say that we're very privileged to have Andrea Van Hoover listening in on this session today. She is the Deputy Director of the American Society of Echo and the American Society of Echo Foundation, which is intimately involved in the outreach of the American Society of Echo all over the world as an international alliance partners and also in the outreach events. And this is really a commitment. She's staying up late to watch this. It's a commitment on the part of the ASC to the international mission that we all learn together in promoting the best quality cardiac ultrasound that we can. So again, I want to thank Dr. Nguyen, Dr. Hoai Nguyen, and the opportunity to do this. And I want to turn it back to her for the final comments.
Thank you. Thank you so much, Jim. Thank you, Eric. Thank you, Keith. And thank you, Andrea, and all the speakers, excellent speakers. This is a wonderful evening for you, and of course, a wonderful morning for us. We appreciate your great contribution to the education of echocardiography in Asia, and we hope that our collaboration will continue in the near future. And during the pandemic, this kind of tele education is very effective, and we learn a lot from you. And I'm sure that our own attendees in Vietnam and in other nations in Asia really enjoy the session. Thank you so much, and I wish you a wonderful evening. Thank you.
Thank you.
Thank you.
Thank you.
Thanks again. Really appreciate it.
One day, we can all stay healthy, and no one suffers from hunger. We will only realize this vision together. Together, we will come back stronger. Together, for a future with health for all, hunger for none.
My journey continues, and I know I'm not alone. Because together, we can make a difference every day.
One day, we can all stay healthy, and no one suffers from hunger. We will only realize this vision together. Together, we will come back stronger. Together, for a future with health for all, hunger for none.